This patient has a very heavy accumulation of supra and subgingival calculus. The gingiva exhibits the classical signs of inflammation. There are changes in color and in contour, and there is a tendency to bleed with light probing. The scaling operation will be carried out with the ultrasonic scaler. The tip used to begin the operation is P3. This has a fairly large, flat tip, which can be used on most all tooth surfaces as well as for subgingival scaling. With a large tip, more energy can be safely applied to large calculus deposits. The tip is flat and thin, which allows good access to the narrow interproximal areas. Because the tip is applied with very light pressure, it is not necessary to use a finger rest. This allows for considerable flexibility in positioning the instrument for optimum access to all surfaces to be scaled. Keep the instrument in constant motion, but it is only effective when in contact with the calculus. Be careful not to allow any part of the vibrating tip to remain in contact with the soft tissue for more than a short period of time, or it will cause a wound similar to a burn. Do not try to use force to push or break the calculus off the tooth. The vibration of the instrument tip in contact with the calculus is all that is necessary to remove it. After an area of scaling has been completed, it is then checked to make sure there are no remaining deposits of calculus. With the unit off, the tip may be used as an explorer to locate the deposits of calculus. After activation of the unit, you will notice some loss of tactile sense. In accomplishing subgingival scaling, carry the instrument tip apically along the root surface until the soft resistance of the epithelial attachment is felt. Carry out the scaling operation coronal to this point until the root surface feels smooth. Either a vertical or horizontal motion may be used in scaling. Keep the tip in motion, but in contact with the root surfaces being scaled. It requires care in following the contours of the root surface. This is particularly true when using a horizontal motion in scaling the interproximal areas. Access to the subgingival area on the midfacial and midlingual of the narrow incisor teeth may be difficult to obtain with the flat P3 tip. It may be expedient to change to the smaller P10 tip after all accessible areas have been scaled with the flat tip. The P10 tip has a sharp point and may be used as an explorer to locate any remaining accumulations of calculus. However, be careful not to activate the unit with the point in contact with the root surface. It could cause damage to the surface of the root. The actual scaling operation should be carried out with the side of the point. After all areas have been scaled, and no more calculus is detectable with the instrument tip, then each root surface should be very carefully checked with the explorer. This will assure you that all remaining calculus has been removed before starting the root planing operation. The Gracey 7/8 Curet will be used for root planing the teeth in this segment. Insert the instrument carefully into the interproximal area and then carry it apically in the exploratory stroke. When the soft resistance of the epithelial attachment is felt, the working stroke is begun. Move the instrument in a coronal direction. Repeat this procedure with the exploratory stroke by going apically to the epithelial attachment. In the working stroke, the instrument is drawn coronally in firm contact with the root surface. Continue this procedure until the root surface feels smooth to the instrument. If, after several working strokes, the root surface still feels rough, check your instrument for sharpness by applying it to the thumbnail. The instrument is sharpened with a fine India handstone, number FS 34. Check it again on the thumbnail for sharpness. Then wipe the instrument with a sterile sponge to remove any fingernail particles. Be sure to make the exploratory stroke and the working stroke two distinct procedures. Use the push or exploratory stroke to determine any area of roughness on the root surface and to determine when you have reached the epithelial attachment. The pull or working stroke is used to smooth the root surface. Always precede the working stroke with the exploratory stroke in any area of the root surface to be planed. The instrument is held in a modified pen grasp with the third or ring finger being used for a finger rest. This resting finger should be in firm contact with the teeth at all times. Activation of the instrument in both the exploratory and working stroke is accomplished by movement in a short rotational arc around the rest finger. This motion is provided by arm rotation or wrist flexion. If the fingers are used to activate the instrument, they will fatigue very quickly and cause a loss in sense of touch and control. Use the fingers for activation only when absolutely necessary to achieve proper access and control of the instrument. A horizontal stroke is used to root plane the midfacial and midlingual portion of the root surface. The exploratory stroke is used to ascertain the level of the epithelial attachment, and the working stroke is accomplished coronal to that position. Plane all root surfaces in this segment until they feel glassy smooth to the curet. Then use an explorer to carefully check all surfaces or any remaining calculus and make sure the root surfaces are smooth. This exploratory procedure should be carried out with great care. Each square millimeter of the root surface should be checked and determined as smooth. If an area is found to still be rough, then it should be re-instrumented. Effective root planing as an adjunct to good plaque control by the patient should result in excellent tissue resolution following initial therapy. One week post-operative observation indicates a reduction of marginal gingivitis and the interproximal enlargement. There is a beginning return to normal gingival architecture.
Skip the paragraph. I'm sorry.
In the lingual aspect, there is a marked reduction of the gingival enlargement and a good reduction of the marginal inflammation for such a short post-operative period. The 6 weeks post-operative observation indicates an excellent resolution of the gingival inflammation. Plaque control procedures by this patient are excellent. The marginal tissue shows good tonus and no tendency to bleed. The inflammatory enlargements have resolved, and the gingiva has assumed a more normal architecture.